T-cell become activation. And then for PI concept, that is a small molecule, such as in the carbamazepine or the other cell, that can directly bind to the T-cell receptor or cause the MSC, HLA-DR, that causes the symptom come out. So if we want to know for the drug allergy, the immunological mechanism, we will just on the very infant stage. We don't know how come the drug will activate the T cell and go the other way. So I think back to our clinical, we have to know that it's very high chance when you give the medication to the patient, you have to know definitely some of the adverse drug reaction will come out, and if the patient have a genetic susceptibility, it will cause the drug allergy. So firstly, if the patient have a symptom come out, we have to ask for the history, make a detailed drug medication, and to know is the immediate type of the T cell type hypersensitivity reaction. And then for the confirmation, of course, you have to do the skin test or maybe the other so-called serological to find out specific IgE. But these two parts is actually, if you just only use these two parts to make a diagnosis, I think the correct diagnosis may be below 10%. A lot of correct diagnosis have to depend on drug history as well as clinical history. So even our textbook have suggested that if we want to do a confirmation of the drug allergy, you have to do the drug publication test. But I don't think that is realistic, because for the drug publication test, somebody you have to use a lot of medical resources as well as to let the patient know if this drug is not good for you, and sometimes it cause the damage of you. So for the laboratory test or for the serial reaction, even when the patient you don't know is this really due to the drug that causes anaphylaxis. So previously, when you take the reference, you found that you can measure for the histamine or the tryptase from the mast cell, and even you can collect a 24-hour urine to find out any histamine metabolite in the urine. But I will just only want to emphasize that it's just only for the research purpose, because the patient already have a very strong and a very clear anaphylaxis symptom. You never use this kind of test to know that is already have an anaphylaxis coming out. So definitely you have to depend on the clinical presentation. So the test, like I said, using a tryptase test or patch test, that was just only for the future confirmation that the patient will go to evolve in the near future. So this patch test that will cause the sclerosis. And finally, if the patient cannot avoid this kind of drug, such as this is a leukemia patient, and they have to use the rapamycin or have to use the mercomycin, and you have to. So the patient really needs the drug. So you have to know, is there any possible that we can do the drug desensitization or to do the drug publication test? But one of the very good speakers talking about the drug allergy, she is quite expert in the drug allergy, said, when we're doing the drug publication test, we are not to rule out the drug. Actually, we just want to confirm it's really is the drug that causes the symptom. Right? So you have to admit the patient to the world and to do the test. And if the patient got any drug reaction coming out, so we have to do the so-called classical management for the anaphylaxis. You have to give it as quickly as possible to give the epinephrine. And Professor Takao, which someone have mentioned, is to treat the anaphylaxis, to prevent the anaphylaxis shock, and to give the antihistamine and stop the drug. And if they already occur for the delayed type hypersensitivity reaction, we have to use a large amount of a systemic steroid to prevent the continued symptom. So is it possible to make a desensitization? I am not very have a confidence about to use the desensitization to treat the drug allergy. because a lot of cases you cannot use it, such as now in the Stephen Johnson or the other drug reaction coming out. So for the desensitization, you have to gradually titrate it and do it in one or 2 days to get a good result. But some of the good result is not due to the tolerance. Some part is due to the a lot of mechanisms we still do not understand. Because I don't believe if you use the desensitization, you can prevent the drug interaction, such as directly go through the hapten or hapten. Alright. So I think the most important thing is to prevent. You have to do the prevention, and we not just only have to educate for the patient. We have to educate our pharmacy and educate our doctor. Especially for the drug allergy, is the one thing is more effective is when the patient got any symptom for drug allergy. We can prevent it as well as to treat it. So the last part is that because Professor Kuchisawa already mentioned that how to treat the anaphylaxis. Because for the anaphylaxis, they have a lot of risk factors because the patient already have an atopic symptom, like they have a food allergy or asthma, and then they have a lot of chance to get easily sensitized. And so a lot of area they will cause anaphylaxis because Professor Kuchisawa already mentioned the food allergy also will cause anaphylaxis. So I don't want to mention it more. And so we have to prevent it and know that a lot of cofactors will cause anaphylaxis. And if you got particularly a lot of IT dependent food allergy, skin or drug will cause the immediate reaction. And then for the immediate reaction, if we can treat it properly, we can save life. And this kind of, if we delay for the treatment, actually we get a lot of unwanted side effects, or even we will lose life, become a life-threatening. So actually, the most important thing is to see any skin manifestation come out, and if they have an actual skin manifestation like a bronchospasm, we have to do quickly to prevent the shock coming out. And for the anaphylaxis, if you see the patient, they will already have anaphylaxis, they will just only building discomfort, and they cannot tell what's wrong coming out. And suddenly they have a lot of sweating because the parasympathetic tone is already rising. So the meditation is not specific, but it's combined together. You have to be very alert that this patient already have anaphylaxis symptom come out. And particularly for the young infant or children, they cannot talk their symptoms. You have to watch out for the skin manifestation. And then for the sign and the treatment, definitely you have to immediately to let the patient lay down, measure the blood pressure, calling for help, and then inject it for the epinephrine. That is the life-saving. And after that, and then treat it for give it the IV fluid to keep the blood circulation and to do the resuscitation. And if the patient still have an unwanted persistent shock, because don't forget the anaphylaxis have two phases. One is the immediate phase to cause the blood pressure coming down. And if you correct the first phase, sometimes they also have a lot of tryptase and histamine release. So and will attract a lot of inflammatory cells. They will cause the biphasic response. So some of the biphasic response you have to admit the patient to the ward. So if the unresponsive for the initial therapy, the patient has to be hospitalized and to take care of the other symptoms come out. So for the patient, for the anaphylaxis, actually we can save this kind of patient. And if you do this immediately and correctly. But if you don't have any alert and know that this symptom, you are going to lose life. Right? And so in the wall, they have recommend if you got a previous drug allergy history or food allergy history, you should carry a pen, epinephrine pen, and that will become a nice therapy. That is my last slide. Thank you very much for your listening.
Xin cảm ơn phần báo cáo của giáo sư. Thank you for Professor Wang presentation. Sau đây thì xin trân trọng kính mời Phó giáo sư tiến sĩ Lâm Thị Mỹ thuộc Bộ Môn Nhi Đại học Y Dược Thành phố Hồ Chí Minh sẽ trình bày bài bệnh suy giảm miễn dịch bẩm sinh và đột quỵ giai đoạn 1. Xin trân trọng kính mời cô.